Hello everybody. Today we are going to discuss about atrial fibrillation in ICU. Atrial fibrillation is the most common arrhythmia in patients hospitalized in the intensive care unit. It is associated with the increased morbidity and mortality. So management of patient with the hemodynamic instability. So if the patient is hemodynamic unstable, we need to go for the electrical cardioversion. Electrical cardioversion can be performed safely in sedated patient treated with IV midazolam and propofol or etomidate. Monitoring and oximetry during procedure should be used routinely. Crash cart should be ready. Intravenous atropine and the isoprotenolol or temporary transcutaneous spacing should be available in case of post-cardioversion bradycardia. Biphasic defibrillator are the standard because of their superior efficacy compared with the monophasic defibrillator. Anterior posterior electroposition restore the sinus rhythm more effectively. According to ACLS, the dose of synchronized cardioversion is 120 to 200 joule for narrow irregular rhythm. Pre-treatment with amiodarone, flecainide, ibutolide, and the propafenone should be considered to facilitate the success of electrical cardioversion. Now about management of the hemodynamically stable patient, about rate and rhythm control. Rate control target the optimal ventricular rate range. Heart rate should be less than 110 based on the findings of the race trial. So the race trial was published in the NEJM on 15th April 2010. The background of this study was rate control is often therapy of choice in atrial fibrillation, and guideline recommended strict rate control, but this is not based on the clinical evidence. So they hypothesized the lenient rate control is not inferior to the strict rate control for preventing cardiovascular mortality in patients with permanent atrial fibrillation. So the drug used for the so what they have studied is they have randomly assigned 614 patients with permanent atrial fibrillation to undergo lenient rate control strategy or strict rate control strategy. So the primary outcome was composite of death from the cardiovascular cause, hospitalization, heart rate, stroke, systemic embolism, bleeding, and the life-threatening arrhythmic event. And they found no difference between lenient and the strict rate control in patient with the atrial fibrillation. Drugs used for the rate control are beta blocker, first line beta blockers. These are the first line rate control agent. The prognostic benefit of the beta blocker seen in heart failure with reduced ejection fraction. Beta blocker that are commonly administered in the atrial fibrillation are metoprolol tartarate, metoprolol, bisoprolol, atenolol, ismolol, landilol, nebivolol, and the carvedilol. The non-hydropyridine calcium channel blocker. These are the verapamil and diltiazem that provides the rate control. It improved the atrial fibrillation related symptom compared to beta blocker. So dose of the verapamil is 2.5 to 10 mg IV bolus over 5 minutes and diltiazem 0.25 mg per kg IV bolus over 5 minutes, then 5 to 15 mg per hour. Digoxin inhibits the sodium potassium pump, increasing the calcium availability in the contractile apertures. Digoxin controls the ventricular response to the direct action on the AV node and by centrally mediated vagal stimulation. On the other hand, positive inotropic effect of digoxin may be beneficial for patients with heart failure. So the dose of digoxin is 0.5 mg IV bolus. High plasma level is associated with increased mortality and check renal function before starting an adapt dose in CKD patient. Now about adverse effect, digoxin can cause broad spectrum ventricular supraventricular arrhythmia due to ectopic rhythm, pacemaker depression, and conduction abnormality. It can also cause visual disturbances, nausea and vomiting are typical extracardiac manifestation of digoxin toxicity. Digoxin and the digitoxin are not effective in patients with increased sympathetic drive. Amiodarone can be used as a last resort when heart control cannot be controlled with the combination therapy in patients who do not qualify for non-pharmacological rate control. If amiodarone we can administer in the dose of 300 mg IV diluted in 250 ml of 5% dextrose over 30 to 60 minutes via central line, followed by 900 to 1200 mg IV over 24 hours diluted in 500 to 1000 ml via central. Atrioventricular node ablation in the pacing. Ablation of the AV node and the pacemaker implantation can control ventricular rate when medication falls. So these are the recommendations from the ESA guideline. Beta blocker, diltiazem, verapamil are recommended as a first choice drug to control heart rate in atrial fibrillation with left ventricular with ejection fraction of more than 40%. Beta blocker digoxin are recommended to control heart rate in atrial fibrillation with ejection fraction of less than 40%. Combination therapy comprise different rate control drugs should be considered if a single drug does not achieve the target heart rate. Resting heart rate of less than 110 should be considered as an initial heart rate for the rate control therapy. Then atrioventricular node ablation should be considered to control heart rate in patient unresponsive or intolerant to the intensive rate and the rhythm control therapy and not eligible for rhythm control by LA ablation, accepting that the rate patient will become pacemaker dependent. In patient with the hemodynamic instability, severely depressed LV ejection fraction, intravenous amiodarone may be considered for the control of heart. Now about rhythm control. Rhythm control strategy refers to the attempt to restore and maintain sinus rhythm. It is done by the synchronized cardioversion method. There are two types of synchronized cardioversion, that is electrical and pharmacological. Vernaculant is the new antiarrhythmic drug that targets the atrial specific channel and has been approved for pharmacological cardioversion in atrial fibrillation of less than 7-day duration. Vernaculant is given intravenously at initial dose of 3 mg per kg over 10 minutes. If cardioversion fails, second dose is 2 mg per kg after 15 minutes. Adverse effects should not be used in patients with hypotension, recent atrial acute coronary syndrome, prolonged QT, and severe aortic stenosis. Then this is the amiodarone that we can use for rhythm control. Adverse effect, hypotension, bradycardia, AV block, QT prolongation. Then we can also use for rhythm control flecainide and propafenone. The dose is 200 to 300 mg, that is 2 mg per kg over 10 minutes. Then propafenone 450 to 600 mg, that is 1.5 to 2 mg per kg over 10 minutes. Adverse effects should not be used in ischemic heart disease and significant structural heart disease. May induce hypotension. Flecainide may cause the mild QRS widening. For pharmacological cardioversion of recent onset AF, vernaculant or flecainide or propafenone is recommended. Intravenous amiodarone is recommended for cardioversion of AF patient with atrial fibrillation structural heart rate if a delayed cardioversion is consistent with clinical situation. Pharmacological cardioversion of AF is indicated only in hemodynamically stable patient after consideration of thromboembolic risk. Effective anticoagulation should be initiated as soon as possible before every cardioversion. Early cardioversion can be performed without T or transesophageal echocardiography in patient with AF of less than 48 duration. In patient with the atrial fibrillation of more than 424 undergoing cardioversion, therapeutic anticoagulation should be continued for at least 4 weeks, even after successful cardioversion to sinus rhythm. When thrombosis beyond 4 weeks, the decision about long-term oral anticoagulation treatment is determined by the presence of stroke risk factor. When thrombosis is identified on the transesophageal echocardiography, repeat transesophageal echocardiography to ensure thrombus resolution should be considered. In patient with definite duration of atrial fibrillation of less than 24 weeks and very low stroke risk, post-cardioversion anticoagulation for 4 weeks may be omitted. When thrombus is identified on transesophageal echocardiography, effective anticoagulation is recommended for at least 3 weeks before cardioversion of atrial fibrillation. So, which one is better, rate control or rhythm control? So in this trial, in atrial fibrillation with in patient with atrial fibrillation congestive heart failure, a routine strategy of rhythm control does not reduce the rate of death from cardiovascular state cause as compared with the rate control strategy. Now, this was another paper which was published in NEJM, that is early rhythm control therapy in patient with atrial fibrillation. So, early rhythm control therapy associated with the lower risk of adverse cardiovascular outcome than usual care among patients with early atrial fibrillation and cardiovascular condition. Thank you, guys.